Hello, this is Dr. Gabriel Chu from Surrey, British Columbia, practicing at the Fraser Valley Cataract and Laser. And in this video, I'm doing a lens exchange where I'm going to exchange this lens with a toric lens. In this particular patient, he had cataract surgery several months ago. But he had residual astigmatism after implanting a monofocal lens, and we're planning to exchange the lens for a different power, as well as for a lens that has toricity built in, so he can be relatively spectacle independent for the distance. After remaking my paracentesis and my 2.5 millimeter main corneal wound, I reinstilled the anterior chamber with 1% non-preserved lidocaine. I really want to get the lidocaine underneath in the sulcus area, underneath the iris, to get better local anesthesia. Here, what I'm doing is I'm injecting viscoelastic around the edges of the lens. As you can see, there's quite a bit of capsular fibrosis around the lens already after several months. And what I'm trying to do here is free up the capsule from the lens and its haptics, of course, without compromising the integrity of the capsule. But given the level of fibrosis, I am being careful as to how aggressive I am with breaking the capsular fibrosis. So I'm alternating side to side, trying to see if I can rock the lens side to side and get underneath the lens, which I managed to do there, to separate the posterior capsule from the posterior part of the lens. And I'm especially paying attention to the haptics area and the optic-haptic junction, where there's a high amount of fibrosis, injecting viscoelastic both above and below the haptics to separate the haptics from the capsule. How I recognize that the capsule is free from the lens is when I move the IOL, then the capsular complex doesn't move with it. And I'm continually trying to rotate the lens to see if the haptics are free. And slowly but surely, I free the capsule from the lens. Once I feel there's some good movement, I'll switch over to my angled Sinskey or straight Sinskey. And as you can tell, I can just pop the haptics from the capsular bag. And what I'm doing is I'm dislocating the lens from the capsule into the sulcus / anterior chamber. And what I'm showing in the video there is I'm planning how I'm going to explant this lens through a 2.5 millimeter wound. So in my para, I'm going to put in my micro forceps. And in my right hand, I have the micro scissors. I didn't make my paracentesis big enough to allow for the diameter of the micro instrument, so I'm going to increase it from maybe about a 1 millimeter to 1.2 millimeter paracentesis to allow my instrument to get through. You'll see that I'll need counter traction in order to cut this properly within the eye. It's important for me to grasp and cut very close together, so I don't get a lot of twisting and movement of the lens while it's in the anterior chamber. The last thing I need is for this to move too much and cause, number one, too much patient discomfort with with the lens touching the iris, or number 2, even worse, touching the endothelium. And sorry for the video here, it's a little bit out of focus, but I had to move from move from a micro instrument to a Vanna scissor. This lens, I believe, is an acrylic lens. I don't know what type, I can't quite remember, but it was harder and I wasn't able to get through. But as you can tell, even with Vanna scissors, it's fairly large, so you have to be very aware as to where your inferior and where your posterior and anterior limits are of the scissor, to make sure it doesn't damage anything like the capsule underneath or the corneal endothelium above. So what I did there was I had my forceps as countertraction, and I had my Vanna scissors cut vertically to cut the lens into 3 pieces. With, I believe I'm using non-tooth forceps there, straights, to remove the 2 pieces. And in order to get this in the right position so I can just pull it straight out of the wound, I rotated it so that the haptic won't get caught on the wound. So once I rotate it in this orientation, I'm able to just come in with non-tooth forceps and just basically take it right out of the wound without having to expand it. So that'd be the ideal, so we don't have to make the wound any larger and cause any unnecessary astigmatism, or make any larger of a wound than we have to. Now I'm preparing the anterior chamber and the capsule for receiving the new lens, and I'm spending some time here just to show you what I'm trying to do with the new lens. And likely what I'm going to do, because there was a lot of fibrosis where the original IOL was sitting, I might put the new haptics in a new orientation if I can. Of course, when I'm doing this, I want to make sure that the lens can center properly, and there's not residual capsular fibrosis that causes the lens to decenter. And as I'm loading my IOL into the injector here, I'm thinking about where my orientation of the lens should be, and what orientation or what kind of centration I'm going to have with the new lens here. So 0.12 provides countertraction, so I can get my tip right into the anterior chamber. I'm injecting straight into the capsular bag, where the leading part of the lens goes straight in. Without using the Sinskey, I'm going to go straight in with my IA tip. Push slightly posterior to situate the lens inside the bag, and also at the same time as I'm removing the viscoelastic, I'm turning the lens to see if I can get it into the right orientation here. Because I use a cohesive viscoelastic Healon, it comes out quite easily. Here I'm having a little bit of trouble with the fibrosis to get the lens in the proper position. But I did manage to get it into the right position, into the right axis for the toricity. And I'm fairly happy with the centration and the new positioning of the lens. So what I'm doing is I'm just reinflating the anterior chamber now and seeing how the lens eventually sits. As I'm doing this, I'm going to try to reposition the lens if I feel like it's a little bit off, while I'm reinflating the anterior chamber and sealing the wounds. All in all here, I think it went quite well, considering the amount of capsular fibrosis. I was able to preserve the anterior and posterior capsular integrity. And by breaking up the capsular fibrosis and dissecting it out gently with viscoelastic, I was able to open the bag enough so that the new lens was received quite well. And as you can tell here, it centers nicely. Good. And there's my typical process for a lens exchange. The only difference here is that I usually like to use my MST Micro scissors and forceps, but for some reason the scissors didn't work very well, or it wasn't sharp enough to cut through the acrylic lens, so I had to switch to a Vaniss scissor, which is, it works. It's not ideal because it's larger and a bit more bulky, and you just got to be a bit more careful about damaging internal structures. But it does work, especially if you have counter traction with the forcep. Thanks for watching.